So I think we are ready to go. I trust that Eric will text me if something's not working right, so I'm going to go ahead and get started. And so thanks everybody for joining this afternoon for another just lunchtime chat on a little quick COVID update. Again, my name is Gerry Parker. I'm Associate Dean for Global One Health at the College of Veterinary Medicine and Biomedical Sciences, and also the Director of the Pandemic and Biosecurity Policy Program at the Bush School of Government and Public Service. And just as a reminder, started this after we completed the spring semester and wanted to offer it for students that wanted to continue to have a dialogue and a discussion and get an update of COVID-19. And also anybody else that wanted to join. So again, thanks everybody for joining. And I'll try to go through this update pretty quickly, and then if anybody has questions, please put them into the chat box, and then Eric will help kind of moderate a Q&A as we get to this PowerPoint. So hopefully we can make this more of a dialogue and a discussion rather than a one-way conversation from me to you, because although it's kind of hard to do on Zoom, we can probably do some discussion. So with that, what I want to do is really just an update, some of the data that you've been watching before. I'm probably getting used to the way I make the charts and try to make all the charts pretty similar so they're easy to follow and really just follow and just get a visual. Are we going up? Are we going down? Are we staying the same? And that visual, I think, is very helpful. There's been a lot of news this week also in vaccine development, and I think some progress. And so I just wanted to kind of review where we're at with the vaccine development, and also then kind of close up with what I think are national, state, local priorities as we move forward in our COVID response and actually COVID preparedness as we get ready for the next phases of this. So here we are, the global picture. As this data, the data is either going to be as of the 22nd or the 23rd of July, and the data that I take either comes from the Johns Hopkins data repository or the Johns Hopkins testing initiative, and then the Texas Department of State Health Services data repository. So as of 22 July, over 15 million cases, and we continue to go up, and over 600,000 deaths worldwide. And the deaths kind of looks like it. I'll just use my pointer so we can see this line right here is our 7-day moving average. This red line is our cumulative cases, and this axis will be the cumulative cases, so you can get an idea of those numbers. And then this axis over here on the left side is the daily new cases, and then the numbers of that. But you can really kind of get a very good picture of we're going up, staying the same, or going down. And so with our global new deaths, actually, it's not really going up. It's, I would call this on the 7-day moving average, and even if you look at the peaks, daily new peaks, it is plateaued despite the fact that we have this really significant continued increase in daily new cases. And I guess one other comment maybe back, I thought about this. Let's see if I can go back. On the global stage, the United States makes up well over a quarter of these new cases in total cases. And it's probably United States, Brazil, Russia, and India, and some in the Latin American countries as well, are making up the predominant of the new cases right now. So the United States, we have a really significant kind of steep uptick in cases over really since the middle of June. If there's any good news right here, that 7-day moving average, it's not a trend yet, but at least there's a little bit of a plateau on that 7-day moving average, and you can even see it in the daily new cases. So we have over 4 million cases. in the United States, and we have over 143,000 fatalities in the United States. And we have a very, very steep really increase in here. But fortunately, the deaths have not been going up. Maybe there's a little bit of an uptick here the last couple of days, but fortunately, the deaths have not been going up as steep as this. And this has even been, this is mid-June, and if we were going to start seeing a big steep increase, we'd probably be seeing it about right now. So maybe the next few days is going to be kind of critical, but hopefully we're starting to see a plateau. I'm going to go back and take a look at New York, because that's really where the hotspot started in the United States, and New York went through a very, very critical period and experienced really a high number of deaths. You know, they actually have over 32,000 deaths have happened in New York State alone, and they had over 400,000 cases. Now, kind of remember this next two charts will be kind of important as we take a look at the whole total number of cases, total number of deaths in New York versus Florida and Texas. So Florida, total number of cases as of the 22nd of July, 380,000 compared to 400,000. So actually Florida is approaching the same number of cases that New York had. And you know, unfortunately, you know, both the cases are going up very, very steeply in Florida. Maybe again, maybe a little hint of a plateauing, downward plateauing the last few days, but also the deaths have increased quite significantly in a very steep rate in Florida as well. And the total deaths in Florida, a little over 5,000, but compare that to New York, 32,000 deaths in New York, kind of the same number of cases, but New York has really experienced a significantly more fatality rate than did Florida, so to date anyway. And in Texas, kind of the same story. You know, we're up at 363,000 cases over in Texas now, and since mid-June, we've had a very, very steep increase in the number of daily new cases, and we've also had a significant, with a little bit of lag when it started here, we've seen a significant uptick in increase in fatalities as well in Texas. But again, you know, at least we're not in the league of what New York State experienced. As tragic as it is, it could have been a lot worse. And so again, just kind of unpack Texas a little bit and kind of, you know, where we see the cases again. It's the Dallas-Fort Worth area, the greater Houston area, the I-35 corridor, down in South Texas, El Paso, and then we had a hot spot that's been kind of resolved in the Panhandle for a while. So I just want to look at a couple of these regional areas in Texas. And so first is the I-35 corridor, includes Bell County, Bexar County, Comal County, Hays County, Travis County, and Williamson County. And we've had an increase in cases. The scale kind of, this one aberration really kind of messes with the scale here. And without that one big aberration, if that would have been spread over these days, we would see a more steep increase. But nonetheless, there has been an increase in cases in this I-35 corridor, and there's been a definite increase in the number of fatalities we've had in the I-35 corridor. Now we look at the greater Dallas-Fort Worth area, and there's 4 counties that I've combined into this being Collin County, Dallas County, Denton County, and Tarrant County. And we definitely have experienced an increase in cases. And again, we kind of have this one-day aberration of cases where a lot of data and tests came back and were thrown into this one day, and it does skew the scale, but nonetheless, we see an increase in cases, and we've seen a slight increase, I would say, in the fatality rate as well in the Dallas-Fort Worth area. And then where we've really had an increase in fatalities and cases is down in South Texas and Hidalgo County, Cameron County area. And then closer to home, Brazos County. Boy, it seems like actually I would call this a downward trend that we're seeing at the moment in Brazos County, which is kind of good news. Not kind of, it is good news. You know, we are up over 40 deaths now, though, in Brazos County. And this is just kind of the nature that, whenever, how it's been reported in Brazos County, we will go several days without a death, and then we'll get a reported death, or we may get reported 2 deaths. But we've had over 40 deaths here in our own hometown of Brazos County. But at least at the moment, it appears that we're on a downward trend of new cases in our county, and that's good news. A testing summary. Actually, this has also improved since the last time that we met. The last time we met, I'm going to pay attention to this number more than anything else. It's the positivity, the ratio positive test to total test. And the last time we talked, this was up like 17%. And we're moving it down in the right direction. We really would like to see this under 3 to 5. It's still too high, but at least it's moving in a downward trend, and that's good. What that means is perhaps a higher number means we have community transmission. A lower number means we're getting the community transmission under control. So we are moving in a better direction with this. It still means we have community transmission, but it is at least moving in a better direction. And this is as of yesterday, so it's real similar to the data I had in the chart. But anyway, this is the number I wanted you to pay attention to. And actually, this is a really, really good website if you want to look at testing trends across the United States. This is Johns Hopkins testing initiative. That's you can find their dashboard, but if you just search the testing initiative, Johns Hopkins, it really's got some great information and great data. Now, as far as hospitalization in Texas, this is also an encouraging graph. And we still have an increase in hospitalizations across Texas, but at least it seems to be leveling off, and there's a plateau in the number of hospitalizations we have. And in the last day, even a decrease. That's not a trend yet, but at least at the moment, it appears to be leveling off, and that would be very, very good news and an indication that we're seeing less severe disease, although we have almost 9,000 hospitalizations right now. When for the longest time, we only had 1,000 to 2,000. And then finally, I want to show this slide because it really does kind of give some relative perspective when we analyze and look at the data per capita, per million population. And even though at the moment we are experiencing a significant increase in cases, an increase in fatality here in our own home state of Texas, and we have stressed hospitals, and we still have stressed hospitals, particularly in South Texas, but relative to where New York has already experienced, even Louisiana, we've fortunately, even as tragic as every death is, we have not experienced the same degree of seriousness that happened in the state of New York. So we at Texas, our cumulative case fatality rate is 162 deaths per 1 million population, compared to New York, which has experienced over 1,600 fatalities per 1 million population. And even we hear a lot about California and Florida, same story. It's bad, but it's less bad than New York. And even Louisiana is kind of has experienced worse than these 3 states. But anyways, it's important to also look at the data per capita and per population. So let me kind of switch gears. So there actually has been a lot of new announcements this week from Department of Health and Human Services in Washington, D.C. about significant new contracts that have been awarded in support of Operation Warp Speed. And Operation Warp Speed is the vaccine development manufacturing program that is with a goal to really accelerate the vaccine development and manufacturing of some of the more promising, or at least the candidates that are furthest along in the development cycle. And so there were three major announcements just this week, and major funding of some of these vaccine candidates. And just first, before I talk about any of the individuals here that are some of the ones that were in the news this week or more recently, there's over 160 vaccine candidates in some stage of development. It's still just really just unbelievable, the effort that is happening across the world to develop a vaccine. I mean, vaccines, not just one vaccine, but develop vaccines. But perhaps the one that's the furthest along is this University of Oxford Astrazeneca partnership. This vaccine is already in phase 3 clinical trials, and it recently also received a fairly big contract from the Department of Health and Human Services as part of this Operation Warp Speed effort. It's a adenovirus vector vaccine platform. Some of the other two that are probably closely behind that include Moderna, that was originally supported by the NIH and now part of the Operation Warp Speed effort. And it has gone through phase 1 and it's in phase 1, phase 2, expected to go into phase 3 clinical trials this summer, I call it the third quarter of this year, 2020. And Pfizer, BioNTech, a German, Pfizer, US company, and BioNTech, a German company, were also in the news this week and should be expecting to go into phase 3 clinical trials in the third quarter of 2020. So these three vaccine candidates are probably the ones that are at least in the lead in regards to when they are expected to go into phase 3 clinical trials, or already in phase 3 clinical trials. And phase 3 is the last clinical stage of development and manufacture before a vaccine candidate can be reviewed and potentially licensed for use, either full licensure or use under an emergency use authorization, since we're under a declared emergency. But there's some others. Johnson & Johnson also has an adenovector. Well, let me go back to these two. What's kind of unique about the Pfizer and the Moderna vaccine candidate, that they're a messenger RNA vaccine platform. Now, there's a lot of excitement about these kind of candidates because they're, and even the adenovirus vector type candidates, they have a lot of flexibility and agility to take an unknown and quickly develop from an unknown to a known. But these messenger RNA, the downside is we haven't had a licensed vaccine ever using this platform. So it's a little gamble, a little technical risk, but the technology, both mRNA and adenovector vaccine platforms, are very, very promising. And and many more. In fact, there's some local vaccine companies in this area that had adenovirus vector platforms as well that are very promising. So we have Astrazeneca, Johnson & Johnson, Novavax was just also awarded a pretty big effort, and it's a recombinant nanoparticle vaccine platform. Merck is in the game with a vesicular stomatitis vector vaccine candidate, the same platform that was used for their Ebola vaccine that was licensed. And then Sanofi and GSK with a recombinant protein. They're in preclinical phase 1 clinical studies, and Sanofi is going to be interesting because this is going to get some US, France diplomatic issues, I think, underway. This kind of comes down what country will get first access to the doses of the vaccine. If it's a French company, US company, this is going to be interesting to watch diplomatically. And then finally, Inovio is one of the other kind of maybe front runners. And so even though I'm saying these are some of them that have been kind of, more recently getting news through Operation Warp Speed, there's many other candidates. And don't count out the others that are in that maybe not on this list, because there's a lot of promising vaccine candidates that just aren't on this list or are on the top of the list of the Operation Warp Speed. Sometimes it's not the first one that's the best. It may be some of the second and third stage vaccine candidates that may turn out to be the best. And we also have to think about which vaccines are going to be more affordable and which ones are going to be more accessible as we think about providing access to vaccines around the world, particularly low middle income countries. And I'll talk about that a little bit in a minute too. So anyway, there's a lot of progress happening in the vaccine world, but there's a lot of challenges that we still have to overcome. And so the goal is a safe and effective vaccine, and I think it's going to be plural vaccines, and it's also providing access to safe and effective vaccines. And so there's several things I just want to, I think everybody's well aware of the Food and Drug Administration. That's the regulatory body that's going to do the licensure and review the safety and efficacy data. But there's some other committees and federal advisory committees that are also involved. So it's not just one regulatory agency. They're the important one providing, do these candidates meet the regulatory standards for safety and efficacy. But there's a couple other very important committees. One is the CDC and one is the HHS that are federal advisory committees, meaning that we have a lot of expertise from the academic industry and so forth that are non-government that advise the government and all of us on the actual use and deployment of the vaccines in the population. And in the National Academy of Medicine is also, which is our preeminent scientific advisory body in the United States, has also been given a task recently to take a look at, in a very transparent way, as who will get access to the first doses of vaccine, because this is going to be a scarce medical resource once these vaccines are first licensed. Again, either under emergency use authorization or full licensure. So the National Academy of Medicine, in coordination with the NIH, is going to be taking a look at making some recommendations to the U.S. government on priority access to the vaccines. And so that could be, you might think priority access, perhaps those at most risk, those at most vulnerable, they should get access. But there's another way to think about who should get the first access, is that our front care healthcare providers who are extremely high risk of being exposed by taking care of the most severely ill COVID patients, or should it be our critical infrastructure workers? So a lot of things that go into prioritizing who's going to get first access to some of these vaccines. In addition to just the research, manufacture, and clinical trials, we also have to think about some of the other components and logistics of vaccines, and that includes, do we have enough vials? Do we have enough needles? Do we have enough syringes? So Operation Warp Speed and federal government are also working on all those other logistics that going to be supporting vaccine distribution and vaccine dissemination. And there's a difference between vaccine distribution and vaccine dissemination, because we're also going to have a logistics system in place to actually get the vaccine doses into the hands of the healthcare worker, wherever that may be, and then we get our shots. And so this is a huge logistics enterprise when we think about having to do this under a very short period of time. So I just want to summarize. I've talked about this before, but I think it's important to re-summarize what's happening at the national, state, and local level now. I don't think we hear enough from our national leaders about what is our national strategy, what is our national plan. So let me tell you what I believe it is. And so first and foremost, I'm going to come back to individual responsibility, that we all have a responsibility as citizens, as individuals, to protect each other. This is our most important tool at the moment, is our responsibility to each other. And so we have to take social distancing very seriously, face covering, wash hands, stay home if sick. I've talked about this a lot, and you hear it a lot, but avoid getting sick and avoid getting others sick. This is really our most important responsibility right now. Whether or not we have a vaccine in the future, we're going to be doing this for a long time. Then it's protecting at-risk vulnerable populations. We need to strengthen our healthcare and public health capacities so we can quickly test, trace, and triage at community levels. The moment that's very hard because our case counts have gotten too high. This becomes extremely hard to be able to test, trace, and triage when we have so much community spread. We need to, our science continues to look at where the virus is spreading, rates of exposure, population immunity, and then we're also in various communities implementing and calibrating community mitigation interventions as may be needed. For instance, bars have been closed in our area, or maybe, or will any other business need to be closed? I hope not. I think it's very, very important that we keep our economy moving in a forward direction. But individual communities, wherever they are across the United States, are going to have to continually monitor this to see if additional community mitigation measures are necessary. This is going to be a big question, and it's a big question right now as we think about opening schools for the fall. And then I've already, some of this, we continue to develop therapeutic, post-exposure, prophylactic treatments. We have to maintain our hospital surge capacity so that we can provide critical care for those who experience severe illness. And then we have to make sure that we're securing our essential supply chains. And there are still reports of inadequate supplies of the supplies to keep our frontline health care providers safe, such as personal protective equipment and N95 respirators. We still have reported shortages there. And I've already talked about implementing Operation Warp Speed and the vaccine development program, determining priorities for that vaccine access, logistics, and so forth. But importantly, this is something that I haven't heard this last bullet discussed. And I think it does need to be discussed in a very open, transparent way, that we do need to coordinate with international partners. It's not enough just to immunize the United States or the UK to immunize UK. We have to work with international partners, particularly in the high-income countries, to figure out and establish policies and resources to provide access to low middle-income countries. This is something we're not talking about yet. It's a big issue. It was a big issue in 2009 with the H1N1 pandemic, and we didn't get it right then. And I don't think we're getting this right now. But hopefully somebody's talking about this. It is very important that we talk about access to low middle income countries. I know US taxpayers don't like to talk about that, but it's something we're going to need to talk about. And then I'm going to come back. It's worth repeating because of the importance of individual responsibility. And I do think that we need to have more research to know how to better communicate the role of individuals in social distancing, face covering, washing hands, staying home and sick, and so forth. But until we have additional research that tells us and guides us on how to better communicate, it's worth repeating to all of us. And please, if you can be ambassadors to your friends and colleagues and neighbors about how important these individual responsibilities are, I think we'll lessen the likelihood that we'll have to have more draconian community mitigation measures than what we have right now. But it's going to be important. Social distancing, face covering, I think is going to be with us for quite some time. And I would say even probably after we have a vaccine. So I'm going to stop there. And let's see if I can stop the share and see if there's any, see if there's any questions. And Erica, if I could look to you to perhaps maybe try to moderate some questions, that would be fantastic.
Sure, happy to. So we had quite a few questions that were submitted both beforehand and in the chat box today. So you have your work cut out for you for the next 30 minutes.
Very good.
So quite a few of them that came ahead of time and a few that came in the chat box are about vaccinations. I'll kind of group them together because I think you have answered some of those questions, but some of them are your predictions basically about how do you think the administration of vaccines will be handled once we get them, and who will be next to get them after healthcare workers and essential government officials?
Well, I think actually there's no doubt that, in my opinion, that healthcare workers need to be first in line. They need to be first in priority to receiving the immunizations. Then I do think we need to determine, who will be highest risk for severe disease. And some of that's going to also be predicated then on that, or how, and this is why I do not have the direct knowledge of how we're doing the clinical trials, because a vaccine will be licensed, have an indication for use depending on how the clinical trials are designed. And so we know that actually those who are older, like me, often aren't the ones that are in the first clinical studies. Usually it may be the 18 to 50-year-old. And so, but if the clinical trials are not including the 70-year-olds, then it won't be indicated for us. And so some of this is going to be dependent upon, how the clinical trials are done. And I think it's, with flu vaccine, it's pretty clear that older individuals over 60 require higher antigen in the vaccine. And so it's not, our immune systems over 60 aren't quite as good as they were when we were younger. And so that will need to be studied and become clear in the clinical studies in the vaccine formulation. So yeah, I would, if it were me, or at least the way I would debate it in some of these forums, if I am asked or get a chance to participate in some of the discussions about it, I would certainly, healthcare providers would be number one. I would also think about other critical infrastructures. I'm not sure about critical government workers, but I would think more about, actually, I would think about national security. I would think about deploying U.S. forces. They would actually be high on my list, and not just because I'm retired military. That's the way we thought about it. I know before, when we did H5N1 pandemic, we have to think about who is going to be necessary to protect the country and make sure that we have the critical things that we need in our country to live. And so energy, the workers that work in our energy, perhaps, so we just have to think about those critical infrastructures, and they need to be high on the list, but no doubt healthcare workers are our most critical infrastructure. We're doing this and protecting those at most severe disease. So I hope that answered it, but it's a hard question. It really is. You would think the initial thought is just, who's ever at most risk gets it. And that certainly is a big principle. And I hope our clinical trials are incorporating that, and the vaccine formulations are incorporating that. But I just don't have direct knowledge of that, at least yet.
Who will make the final decision about who gets them next, other than what's coming through the clinical trials?
Well, the National Academy, the National Academies of Medicine was recently asked to do what they do to bring together study groups and workshops, to bring the right people together, to do a transparent analysis of that, and bringing the right, kind of subject matter experts. So the National Academies of Medicine will have a major role in organizing that discussion and debate to come up with recommendations and a priority list. But at the end of the day, then it'll be the couple of vaccine immunization bodies that I mentioned on one of the charts will have a role in that. And it's hard to say exactly who will have the final say, but more than likely, all that will go into what's called an interagency policy process. And so you would have the federal departments, HHS will have the biggest voice in that, but it'll have the relevant federal departments. All this information feeds into that, but more than likely, they will go with whatever the National Academies of Medicine recommends. That's hard to go against a recommendation by having our nation's preeminent vaccinologists, physicians, ethicists, so forth in that debate. But it'll go through, I'm sure, an this is the way we did in H5N1 and H1N1 2000 when we were preparing for pandemics in the past. It was and the president. I mean, this comes down. It was G.W. Bush that would bless these in the past. So it'd be an interagency process, but the National Academies of Medicine will be what will drive the show.
With that in mind, is there any possibility of making these decisions non-political?
Absolutely. The National Academy of Medicine is non-political. It won't be political. I really am. I'm serious about it. I don't think that's going to be a political decision. It must be done as long as it's done transparently. And I have a lot of confidence in the National Academy of Medicine doing something in a very transparent way to bring the right expertise. And I have a lot of confidence that will not be politicized.
Great. A couple more vaccine-related questions. When do you think those of us in the Brazos Valley will be able to get a safe, reliable vaccination? And will it turn out to be like getting our annual flu shot? So boosters.
Well, the first question, it's really hard to, it's just no way, at this moment, it's hard to predict when we will have access to the vaccine. I mean, the goal is hopefully, in fact, I mean, two of those companies on that list are going to begin phase 3 clinical trials. And although it's a stretch goal, it is conceivable that there could be some doses available before the end of the year. I really think that's a stretch goal. I think it'll be sometime in 2021. But when it would trickle down to Brazos County, it's just too early to predict. And then, I'm sorry, the second question of that, I'm having a senior moment.
I think it was, will it be like getting our annual flu?
Oh, yeah. Yeah. So, again, that's also kind of too early to predict at the moment as well, but there are some scenarios that SARS-CoV-2 virus is going to be around for quite some time and will probably become endemic, and very well may be that a COVID vaccine becomes part of our annual immunization. It very well could be. We don't know enough about long-lasting immunity. We almost have to anticipate at this moment, as widespread as the virus is, that it's going to become endemic after we get through the pandemic stage of this. And that may require annual or periodic re-immunization. And it could mutate then, after some time, and even a new. So we just don't know. But I think we should prepare it could be.
Okay, so there are a couple vaccine-related questions in the chat. I'm not forgetting that there are some other non-vaccine ones that we received ahead of time. But just to stay in this theme, there is one about what does Dr. Parker think about the Russian vaccine that they're administering to their military? They're claiming it's the same platform as their previous vaccines developed, just adapted to SARS-CoV-2. Is it that they're using their military as the clinical trial, essentially?
I have to admit, I'm not up to date on the Russian vaccine, but that intrigues me. I've looked at least at some of the vaccines that are being developed in China, but I have to admit, I haven't looked at the Russian vaccine. And just to comment on administering to the Russian military, I'm not one that proposes that we do our clinical trials in the military at all. Militaries do have unique needs to make sure that the force is protected. But whether you're in the military or not in the military, the human body is the same. And so I'm just, that's just a philosophical approach. And so I hope they're not using their military as their testing ground as opposed to testing their vaccines in the general population, because Russia is one of the countries that experience most of the cases and most of the deaths right now, along with the United States, Brazil, and India. So I hope they're testing and doing their clinical trials in the broader Russian population, but I better not say any more.
Okay, last COVID vaccination related question. Will there be side effects And are you concerned about those side effects to the vaccination?
We don't, I mean, we don't know. I mean, some of the early clinical, almost, let me say this. Almost any drug vaccines that is on the market today will have some level of untoward side effect. And so the goal is to minimize the level of any kind of potential unintended consequences of any drug or vaccines. And so that is why we have such a rigorous, clinical trial process and FDA review and rigor in the manufacturing, research and manufacturing and so forth. Vaccines as well. The most common, I think, side effect with vaccines is tenderness at the site of injection. How many at the site of injection when you get your seasonal flu vaccine, you have a sore arm the next day? I do. But that's an acceptable side effect for perhaps saving your life. And so we don't know yet. But that's why the clinical trials are underway, and even some of the initial phase 1 studies are reporting, some side effects, but that's normal. That's normal part of the process. So they're taking and accounting for and accurately trying to assess, is there redness at the site of injection? Does the injection cause a febrile response? And so those things are going to be cataloged and studied and analyzed for any kind of unusual safety signals. And then hopefully the vaccines that are in development will not have any unusual safety signals. If they do, they're not going to make it. And then it's also, I think, important to realize that, the clinical trials, phase 3 clinical trials are usually 30,000, 50,000 people. I think most of the COVID vaccines are being designed with a cohort of 30,000 people. That sounds like a lot of people, and it is. Often that'll be enough. If there is a safety signal that may become apparent, but sometimes you don't see the safety signals until the vaccine's given in millions of people. And so even after phase 3 studies, there is a phase 4, and it's called post-marketing surveillance. And so that'll be part of the COVID vaccine. Once it's licensed, either emergency use authorization or full licensure, there's going to be a continued post-marketing surveillance to try to monitor and pick up any untoward safety signals that might indicate that there's a problem. And so that's just part of that, and that's part of the normal vaccine development licensure that we have for every vaccine that we use. And so there's a whole system to do post-marketing surveillance, but it'll be, the gain will be turned up on the post-marketing surveillance for the COVID vaccines.
Got it. So moving on to our, the next kind of most requested topic is the reopening of Texas A&M and other local schools. So one of the specific questions was, what are the metrics for re-evaluating TAMU being open for classes in the fall? Well,
I think there's, a lot of the metrics that we are all looking at for just, everything, for Texas A&M to reopen, and we are, right now planning everything that we will have face-to-face. It's really a hybrid face-to-face and virtual instruction at Texas A&M. Most universities are planning that across the state. But certainly some of the things we're watching are what are the case rates in Texas, in our community, in Brazos County? What are the hospitalizations? I think the more sensitive things to look at are hospitalizations, ICUs, and hospital bed availability, ICU availability, and staffing for our hospitals. We hear a lot about beds and ICUs and ventilators, but the long pole in the tent is staffing and making sure that if somebody does get sick, that they're going to have the appropriate physicians and nurses and so forth to be able to care for those who get get serious disease. So those are some of the metrics really going to be watching very, very closely. Here at Texas A&M, going to actually have the ability on campus for testing, symptomatic contact tracing for staff, faculty, and students. Even looking at a few novel things like doing surveillance of wastewater. We're doing research right now to see if that's a viable method that might be able to pick up, be a leading surveillance indicator. That perhaps there's it's sewage surveillance, to put it bluntly, but sometimes that could be for polio. That's actually been a leading indicator whenever where we're still trying to eradicate the last vestiges of polio. That's used as a leading indicator of polio in the community. And so we're looking at that. We're not sure if it's going to be viable or not. And some other universities in the state are looking at that as a leading indicator. But it'll be a lot of just what is the case counts and so forth in our community. And and we'd be naive not to expect that the students come back and we have essentially 60,000 new people moving into college, Bryan College Station. We'd be naive to think that we're not going to see an increase in cases. And fortunately, to date, the younger age demographics have a low probability of serious disease and a very low probability of dying. It is but even in the younger age demographics, there's a certain number of the population that has a comorbidity will put them at higher risk. And so there's a lot of things put in place, because we have to protect those that are maybe more at risk, and that could be our faculty and staff. And so a lot of things are being put in place to social distance in the classroom, and even shields, between professors and students. That's why face coverings are required and so forth. So we're trying to make the classrooms as safe as absolutely possible. We can't say it's going to be safe. We have risk in our life against many, many things. We can never say anything's safe, but we're going to make it as safe as we possibly can.
Great. So is there any particular infection rate or trigger rate for transmission that you would expect would result in a shutdown of any level?
It's going to, I think, to me, it's going to be, it's watching what's happened in our community, in the hospitals, and having the hospital capacity is going to be the biggest thing. Just seeing an increase in cases, whatever that may be, is concerning. But if all of a sudden that increase in cases is starting to fill up our hospitals and we don't have the staff to care for those in the hospitals, and that's a big signal. I can't give you an absolute number, and it's hard to give an absolute number in it, but we're going to work on some of those absolute numbers, but that's going to be one of the more sensitive things.
Just a quick specific follow-up to that is, could individual colleges or departments be shut down if they become hotspots?
I don't think that. I mean, the campus is not that big here in Bryan College Station. So I don't envision that that scenario that one college may shut down. No, I could see. Now we do have. There may be a scenario that could be where we have campuses elsewhere, either under Texas A&M University or under the bigger, broader TAMIS umbrella. We do have campuses really all over the state. And so there could be a scenario where somewhere in the geographic location of the broader TAMIS system, that there may need to be where one part of the system may have to pivot to virtual rather than face-to-face, or the hybrid face-to-face. It's going to be geographic dependent on the local situation. And the public health authorities are going to play a major role. We're going to be guided a whole lot by our public health authorities on what they're recommending.
Thanks. A quick question to clarify from your presentation: is the That 11% positivity rate, is that based on a 7-day rolling average?
I think that is based on a 7-day rolling average. It was from the Johns Hopkins data initiative, testing initiative, and I do believe it is a 7-day rolling average. That's the one graph I didn't do myself. The hospitalization graph from DSHS and the Johns Hopkins testing is yeah. All the other ones I did myself, and they definitely were 7-day moving averages. But I believe the Johns Hopkins web is too.
Okay. There are a couple of questions here about kind of the higher level federal, maybe not just federal, but politicization. So what could have been done to keep the pandemic from being politicized? Is it a matter of leadership style, inexperienced staff? What do you think?
Well, it's a very, very, very good question. You know, and it's going to be interesting when we do the, and I'm going to say first and foremost, I'm going to stay out of the political lane. That's not my lane. I'm going to stay in the medical and public health lane if I can. But I think when we do the after action, there'll be many after actions of this. And I do believe that most of you who listened to me before, we will need to have, and I'm sure we're going to have, at least one major like COVID commission, very analogous to the 9/11 commission after the terrorist attack of September 11, 2001, that must be nonpartisan, which I'm not sure how that can be done in today's climate at the moment, but we'll get through this and in some way we'll do it. But I think it's going to be very interesting when we unwind the tape, but just taking the political stuff out of it. I do think we missed a signal and we missed an opportunity. And I do think we might even be criticized for failure of imagination, like the 9/11 commission concluded after the terrorist attack. It was so unprecedented on 23 January when the city of Wuhan was closed down. And then a couple of days later, Hubei province was closed down. I even remember sending an email back to colleagues here. I was at the NIH when that happened, and I sent an email back to some colleagues and asking, has anybody ever heard of this happening before? And I said, I don't want to raise the alarm, but I don't want to underestimate what had just happened. This is a respiratory virus. It wasn't influenza, but it was a respiratory virus. And to have something that unprecedented, even though we didn't know what was going on, we should have really rang the alarm bell really loud. I even blame myself, because I would come back and do seminars, and some of you came to some of our seminars, and you probably remember me saying, there's no risk right now in our community. And I was, saying, I was also being guided by state public health and national public health. Let's not cause undue harm or alarm, not harm, but undue alarm. But that's a respiratory virus. A whole 60 million people were locked down. I should have said, I feel like I missed an opportunity too, that, maybe right now today there's not a risk in our community, but we better start doing everything we possibly can for that respiratory virus to come to our country. And I think that's where we missed an opportunity. And I think we might have a conclusion in the future that we had a failure of imagination because we didn't listen to that signal. I'll stop there.
Speaking of signals, in a previous presentation, you mentioned that there was a pandemic response plan prepared for President Bush. Is the present administration aware of this plan? And if so, is there evidence that it's being followed?
Well, yeah, there's people in the current administration that know about that plan very much so. I don't know if that plan is actually being followed. Yeah, I don't think, well, let me say this. I don't see a lot of evidence that the plan is being followed. I do think that we, at all levels of government and the private sector, are being extremely still very reactionary, but that happens. That happens during disasters. Even with a good plan, you know, it's the planning process that's important. You know, even in DoD, which is the best at planning for any scenario, it's the process of planning that's important, because every plan changes when you hit battle. And so, and I think there are probably components of that plan. There's no doubt, actually, there are components of that plan being the playbook is being played. It's vaccines. It is diagnostics. Yeah, we got a slow start on diagnostics. Hospital preparedness. Yeah, we got a slow start on that. N95, we're trying to do stuff. We got a slow start on it. You know, so some of the playbook is being played out. But I think where we really missed out is the planning process. And we didn't take seriously, I call it the inter-epidemic period. That's the period between outbreaks is when we can make a difference. And so we really haven't taken pandemic preparedness seriously since the G.W. Bush administration. So, you know, everybody wants to kind of blame what happened in the last 6 months. Whenever we do this COVID-19 commission, we actually have to go back in the Obama administration as well, and the Trump administration, to understand that this didn't, you know, we could have done better in the planning process. I'll stop there.
Okay, real quickly, a couple questions specifically about the fatality rates. So New York had their surge early in the pandemic. Could our death numbers be a reflection of our medical community learning how to treat cases?
Well, I think it is. I think, you know, I think there's a lot at play. I think there's also, I think, a different demographic that perhaps is being higher number of cases than earlier. New York is such a dense population. They also waited to take action later relative to when they were seeing cases and deaths in their community than say Texas and Florida and California. But there's no doubt our healthcare providers are learning how to better care for patients in hospital, and if they slide into the need for intensive care. So it's multifactorial. There's no doubt we're getting better at treating severe illness.
Follow up to that was, do you think that in Texas here that it's mostly younger people were getting infected early?
You know, part of the reason I think in early June is certainly the 18 to 30-year-old had a big spike in the number of cases. That actually coming down, at least in Brazos County. Brazos County is starting to, their data sharing has been pretty good about the age demographics. Still not getting some of the racial demographics data coming out, but no doubt there was a period when we had a big surge in the younger demographics, and that's why maybe we're not seeing quite the level of mortality. That's probably different in South Texas, because we were seeing a really big spike in mortality, fatality in the valley, and a lot of that's going to be related to the comorbidities and probably age. Older age and comorbidities.
Last question, maybe the most important. When do you suggest getting the annual flu shot this year, Dr. Parker?
As soon as it's available, I'm going to get my flu shot. and I would recommend everybody follow their healthcare provider's recommendation on whether or not you should get your flu shot. And I suspect that they're going to say yes, but as soon as it's available, I'm going to get it.
With that, I think we rounded out most, if not all, of our questions.
Well, thank you. I appreciate everybody joining us. And I do want to make a comment that I'm going to need to take a little bit of a break. I'm doing this and probably restart. Hopefully, I can restart this once the academic year starts. But I am, with your indulgence, I'm going to take a break from doing this until the academic year starts. And I hope you're able to join us, because there'll be a lot of new information and the new academic year is just right around the corner. So everybody, I have a new motto, a lot of people kind of get down. We're still kind of somewhat sheltered in place and so forth, but we got to stay positive. Keep a bright mental outlook and try to, treat each other with respect and kindness and dignity. So stay positive, but test negative. All right. Goodbye, everybody.